and welcome to Let's Talk About Menopause. I'm Catherine France, the General Manager of Oxford Women's Health, and on behalf of the team, I'm delighted to welcome you to the first in our Let's Talk About It series. This series celebrates 25 years of Oxford Women's Health, caring for the women of Canterbury, and in fact throughout the South Island, and we're very proud that we do that. It wasn't hard to choose the topic for our first event. Menopause and its many and varied effects are often a hot topic amongst the Oxford Women's Health team. We've shared experiences and tips that we wished we'd known earlier. The scary thing is, we work in a gynae clinic, alongside many experts. And yet, there's still a lot that we're learning along the way, and that's what we wanted to share with you tonight. The message from our experience, and the message, in fact, for this evening, is the importance of talking about it. There are so many life events and experiences that benefit from sharing, especially when it comes to talking girl stuff. In the case of Oxford Women's Health, it's sharing our knowledge so that you are informed. When you have the facts, you can make informed decisions about any treatment options and indeed about your lifestyle choices. So a quick bit of housekeeping. We're aware that you will have a lot of questions following this evening's presentations. However, as you'll appreciate, this isn't the forum for those. You'll note in the flyer that you've been given on your way in that there's a little slip of paper, and there's more downstairs on your way out if you need it. But what we thought we'd do, if you take a moment to write any question you may have on that, and then following this event, and in fact the next one we're having due to the demand, we'll put the answers to a sample of those up on our website, along with a recording of tonight's presentation. You'll also see in that little slip of paper we've included a section about our quarterly patient e-newsletter. We've over 2,000 recipients currently, and are very happy to add you if you'd like to be included to that. But now I'd like to welcome our first speaker. When you work with surgeons, you understand that sometimes things can happen. Fortunately, Richard was held up in theatre, but he's got here to be our first speaker. So thank you, Richard. Welcome to Let's Talk About Menopause.
Thank you, everyone. I'm just going to give, I suppose, a little bit of an overview. I'm one of the gynecologists who work in the gynae clinic. The many experts will be talking to you later. So I just wanted to start. When I was told about this talk, I was actually going second behind the illustrious Anna Fenton, who has got an analogy to bridges. So this is actually better when you've seen Anna, because it's talked about the menopause is a bridge to the next phase of your life. What you don't know is whether it's one of these sort of death-defying experiences to some barren, inhospitable wilderness, or whether it's sort of over the life of five-star luxury. So hopefully tonight we'll be getting more of you down on the right-hand side. This is just sort of, I think something really just to put this in context, and so that the whole idea with this is knowing why this is happening. So when we're all forming inside our mothers, those of us, or those of you who go on to become girls, you form all the eggs that you have. They're all formed whilst you are inside your mother, and that is your lot. You do not make any more. And during your life, they just steadily disappear in the background. So if you do a bit of a mental calculation, saying you're starting with the guts of 1 million, if you think you have periods from 10 to 50, 40 years, that's 480 periods. If you use sort of 10 follicles each time, that's still 5,000. You start with 1 million. So there's a lot that never actually get off the ground. And slowly they just sort of disappear, and then at the end the system stops. But it's not quite as straightforward as that. So this is how it starts. This is my idea of how it starts. This is the inside of an ovary. It's highly stylized. And so you've got these are all your eggs here, and then there's a little man that works on the inside that goes and and he sort of collects what will be the ones that will turn up for January, the ones that you'll use in February. So he's getting them sorted a couple of months in advance, and they're just sort of defrosting and coming out of their deep storage. And what should happen is that you should get this wonderful sort of cycle where the estrogen goes up and then you ovulate and you get this wonderful, smooth process that works. So when you start, it's a bit like The Bachelor or season 1, that you've got all these little wannabe eggs turn up. And these are all the ones that are, this is a tragic insight into how my brain works, isn't it? These are all the wannabe eggs that turn up, and they all sort of start developing. But in true Bachelor style, only one of them gets the rose. And so of all of those 20 that started, only one of them goes through, only one of them ovulates, which means that as far as pregnancy is concerned, it's a chance of just having one child rather than multiple pregnancies. And this is how it should work, because early on it's controlled by Swiss engineers. The system starts and you get a wonderful ending. As time goes by, your warehouse looks like a Russian supermarket in the Cold War. There's not as much to choose from. The number of the wannabe eggs drops off. The Swiss engineers are no longer there. The quality of the oversight and the workmanship is not what it was, and the outcome is not like the fireworks on Sydney Harbour Bridge. And this all comes back to the fact that these are the eggs that you're given at the start, and they're just there, and as time goes by, as we all know, things don't work as well as they did when we're in our 20s and 30s. And so just when you sort of think you've got to the end and you've got no more left, lo and behold, it's like you put that pair of jeans on you've not worn for a while, and you find that sort of $20 in your pocket, or you find some stuff down the back of the couch. Then what you find is that it creeps up, and suddenly from having very few periods or infrequent ones, you then get 2 or 3 turning up on the trot. But there comes, and so you get this sort of very, very sort of fluctuating with some sort of good months, some bad months, and you never quite know where you are. But at some point it reaches the end, and you've had your last egg, and the system stops. So whilst the estrogen levels are falling, all sorts of things will happen, and people will talk about a number of those, and I'm just really going to talk on a couple of these. The first is the older bleeding pattern, and the second is the vaginal skin changes, because as the estrogen drops, the skin changes, certainly where it is receptive to that. And so it's a sort of horrible name, vaginal atrophy or atrophic vaginitis, and it's just that thinning, drying, and sort of inflammation of the vaginal walls. And this is just the estrogen that acts upon these is sort of missing. And so as a result of that, a number of things sort of happen. And I've just put this on because it's just to mention that degree of sort of irritation. And this is, I suppose, the common symptoms, painful intercourse, but also I think people have got this sort of itching or burning, and I think when we're looking at treating people, is this a problem that people have purely during intercourse, in which case you can use some treatments that are sort of designed for the time, or is this something that people actually have, that they have throughout the month, and you need to do something else? Just ignore this, it was just a cut and paste, but it's really just to mention that as time changes and the vaginal estrogen goes down, the conditions inside the vagina alter. And so what you end up with is a change in that environment, so that sort of balance that you have is then often lost. And so people will find that certainly in those sort of perimenopausal years, bacterial vaginosis, thrush, all of these things that are actually not infections, they're just that change in balance, start to become an issue. So the treatment options. So if you think, if someone just has discomfort during intercourse, then vaginal lubricants you can use at the time, because that is the only time that you have symptoms. They don't necessarily need things being done outside of that. If you're having discomfort all the time, or you're having recurrent issues with bacterial vaginosis, then you can use some topical estrogen. So we use this vaginally, and there's Ovastin, which is funded, and Vagifem, which isn't. My sort of impression is that even with people who are on formal HRT, it's great for the flushes and the sweats, but it doesn't necessarily get down into the vagina, and actually using a topical treatment is a benefit. And so this is what we've done historically. We're now in the 21st century, so for those of you who don't know, the Mona Lisa is the vaginal lasering, where you actually can rejuvenate the vagina in a different way. Unusual bleeding, because obviously if you think about what happens normally, your uterus sits there and it responds to the messages that come from your ovaries, and it should be those beautifully sort of synchronous Swiss engineered ones, and so you get a wonderful cycle. But at the end, it doesn't work that way. The messages are up and down, and so what you're really getting is this sort of garbled response. And it's like when you're driving down south and you lose cell phone reception, or the radio sort of craps out and you get all that sort of crackling. And so the uterus doesn't quite know what it's doing, and so the bleeding becomes somewhat irregular. There's nothing here, it doesn't know what's happening, and so the bleeding pattern can be all over the place. And it's that, well, what's abnormal? I think that's difficult, because with this, it's looking at it in a form of context. Is this someone who is just in the perimenopausal phase? Is it someone who is on HRT? In which case, have we caused problems with that? Is it someone who wants to start HRT? And certainly if you've got abnormal, unusual bleeding, then we want to be absolutely certain that there's nothing there before we put you on some sort of hormones that could potentially make things worse. Is it someone who's having abnormal bleeding on HRT and wants to carry on? Do we need to think about the preparation that they're on, or the dosage? What about other issues? Where does it fit in with ladies who have had breast cancer? So there are a number of things that will make everybody's case slightly different. People often talk about postmenopausal bleeding. So the idea is that when your periods stop, they should stop, you shouldn't bleed again. So our definition, because there can be that delay, 2 months, 3 months, 12 months after your last period. If you bleed after that, that is called postmenopausal bleeding. And you think, well, how accurate is that? It's difficult, because it's not like your glad wrap. Your last period does not come out with a little label on it saying, I am your last period. It doesn't work like that, and so we have to have this sort of arbitrary definition, and that is 12 months. And you think, well, why does that matter? Well, there are some issues with that. If you go more than 12 months and you have a bleed, 90% of people, there will be no issue. It will be their last period, or it may just be a little blood vessel that's burst on the inside, like if you have a nosebleed. But for 10% of people, there can be something cancerous or precancerous on the inside. So it's sort of, how do we work out who's in the 10% and who's in the 90%? And so is it just a one-off bleed? Because obviously someone who's done something once, it's much less likely that there's a problem than someone who has had sort of multiple events. We then arrange to scan the uterus, and so we can measure the thickness on the inside, and you would expect normally, because the estrogen has gone, that there is no stimulus, and that lining should be thin. And we would expect it to be less than 5 millimetres. And if it's more than that, then the risks of there being a problem go up. And then it's, what do we do? Well, we really need to take a little biopsy from the inside. And so there are 2 ways. Historically, we've done hysteroscopy, which in old talk was when people came in for a D&C. And the newer way is that we do an endometrial biopsy, where we use a Pipelle, which is like this little thing that just goes up inside the uterus, and you can't see here, there's a double tube, and if you just pull it back, you create a vacuum, and you can just get some of the tissue from the inside. And certainly which one of these we do depends on a number of factors, and I think the point is that if people have abnormal bleeding, we want to be certain that we're not missing anything, and that we're comfortable that you sort of fit into that 10% where there's, sorry, the 90% where there's nothing exciting, rather than 10% of problems. Because going on, it's then, what do we do with you, particularly if you want to go down the route of using HRT? Because there is this sort of if we just give you estrogen on its own, which is what you need to replace what is missing, then we can cause problems, because this causes stimulation, and unopposed stimulation will cause potentially the development of unpleasantness inside your uterus. So we want that balance, and to do that we need to give you progesterone, which is essentially that sort of antidote to what is happening inside the uterus. And whether we do that in a cyclical way, so just as you get to the end and your periods stop, we say, well, let's bring them back. There is this where it is sort of continuous combined for people who are a wee bit further through the menopause. Or for some people, they'll say, actually, what we want to do is put a Mirena in. And so, yeah, there are a number of different ways of dealing with this, and what will suit you or be appropriate for you may not be what is best for your neighbour. And I think that's the end of mine. So that's sort of the introduction. A far more erudite speaker with some proper science, Dr. Anna Fenton, will come now. So thank you.
Thanks, Richard. Our second speaker, as Richard said, it's not necessary that she's far more erudite, but Dr. Anna Fenton is an endocrinologist who has studied and knows all about hormones. She has actually made a career of understanding the menopause. It's actually really been a feature of a lot of your work. I know it's not all that you do, Anna, but she is the menopause queen. And we're very privileged to have Anna on the Oxford Women's Health team. I know you'll learn a great deal from her presentation as well. Thanks, Anna.
That's going to be a hard act to follow, isn't it? Now, this presentation is going to look at kind of menopause generally. So we'll talk about why it happens. We've had a little bit of an introduction to that already from Richard. We'll talk about how long it lasts, the sort of symptoms you might want to kind of learn to expect, and most importantly, the ways we've got of managing that, because that's one of the key messages tonight, is that there are lots of safe and effective ways to deal with the process as it happens. So one of the first things that I did want to emphasise was that menopause is a process. It takes the best part of a decade to go through that dwindling supply of eggs, the hormone changes that go with that. And so the symptoms that we see related to the drop in estrogen in particular actually start a heck of a lot earlier than people really often think. So for instance, we know that about a third of women will start to notice minor changes in their periods, the odd hot flush, a bit more premenstrual grumpiness in their mid to late 30s. And often they're told, you know, you're too young, this won't be menopause. But it often is the very earliest sign that things are beginning to change. And then by the time women get that little bit further down the track into their mid-40s and beyond, then at least a half of us will become much more aware of these kind of symptoms occurring. And I'll show you that squiggly line graph again, but you know, you do get these roller coaster changes in hormone levels over our 40s and in the years leading up to menopause, and that's why symptoms change quite frequently. So there may be good times, not such good times, and everything in between. And then periods obviously stop when that egg supply gets to a very low number. And that's just another version of the graph that you've seen from Richard. So you can see that's a very slow decline in egg numbers over our first 3-4 decades of life, and then you get into your mid to late 30s and they basically fall off the edge of a cliff. And by the time we're into our mid-40s, then as you can see, the egg number has got very, very low. And without eggs, the ovaries really don't make an easy job of making the required amount of hormone. And that's my famous roller coaster slide. So I think there's often a lot of confusion at menopause, because the impression is that we should have hormones that are just sort of gracefully sliding into oblivion. But that's not the case. And so at times, if someone measures your hormone levels, there'll be estrogen levels that are higher than you've ever had before, as well as lower than you've ever had before. And these fluctuations can occur over a day, over a week, over a month. It is a bit of a mess. But that's why sometimes you'll end up with breast tenderness when the levels are very high, hot flushes when the levels are low. So it is pretty variable. Now, this is looking at how long some of these symptoms go on for, because I think most of us approach menopause with this idea that perhaps it's a couple of years and then we're out the other end of all of this. But if you look along the bottom axis, so that's the years before and then after the last period. So the last period is 0 on that graph. And then you'll see the line goes up and it reaches a peak in the gap between 0 and 1. So that's the year after periods have stopped. So at that point, around 70% of women will have some awareness of symptoms related to the changing hormone environment. And then you can see that there is a bit of a tail that continues to wag for a few years down the track. So at the 4-year point from when periods have stopped, about 50% of us are still aware of symptoms related to menopause. And at the 10-year mark, as you're getting right the way out to the right-hand end of the graph here, about 10 to 20% of women are still symptomatic. And in the long term, about 10% of us will just continue to have symptoms in an ongoing way. Now, luckily, that's not most of us. It is only 10%, and those women are a little bit more predictable right from the start in terms of being the ones that will have longer periods of flushing and sweating. They tend to be the ones where the ovaries have been removed or there's been some cancer treatment, so their menopause has happened very quickly, or they're women that have hit menopause very young. The rest of us who kind of do it in the normal way, usually by the time you're getting out to about 7 or 8 years, you're pretty much done and dusted. But by the time you've got the 3-5 years or so before periods stop and then a bit of symptomatic tail, you can see that it does go on for longer sometimes than we might expect. So, what are the symptoms? These are the symptoms that we can reliably pin down to the changing hormone environment. And these are the ones that if we give women hormone therapy, as has been done in lots of research studies, these are the ones that reliably go away. So we know that they're related to the drop in estrogen levels. So the changes in temperature balance can be many and varied. They can be hot flushes, sweats at night, it can be a feeling of greater coldness. And I've got a couple of patients who have had to stop going on tramps because they get so cold they have to then wrap themselves in space blankets to warm up. You have women that feel like they've got ants crawling on their skin, so that's a form of a hot flush, and others that feel like they're about to internally combust. So the heat or the cold can vary from one person to the next. The sleep disturbance, I think, is one of the most important things that changes at menopause. It really alters our well-being because, you know, we tend to wake in the early hours of the morning. It's often because you're hot, but you can wake randomly for no good reason. And it's classically between sort of 2 and 4 o'clock in the morning, which is when your brain's doing all the filing and reorganisation and, you know, the stuff that brains need to recover overnight. So you wake up feeling tired and brain dead. So it's not a great way to then kind of start the next day. Then we see a lot of vaginal and genital changes, and Richard's alluded to those. These are things that most of us as women feel a bit embarrassed to bring up, but it is really important to talk about them. You'll find that doctors are just as embarrassed to ask you, but I just tend to kind of launch in and ask everyone because they're changes that will happen to everyone at some point post-menopause. So whether it's the dryness, the recurrent bladder infections, pain with sex, complete loss of libido, not getting aroused as women might have done in the past, there's a whole range of changes that are quite personal, but you know, can be managed. So really worthwhile talking about them. And then something that's often not recognised as part of menopause are the widespread joint, muscle and ligament aches. So you can feel like you've turned into an old croc. But particularly it's the small joints in the hand. You can wake up feeling stiff and you sort of can flex your joints a little bit and they kind of loosen up. But it can happen to some of the other joints as well. And we often see women that have been through some of our joint specialist colleagues and been diagnosed with fibromyalgia, but they then start on hormone therapy and the aches go away. So this is just as common as the flushing and sweating, but it's often not recognised as part of the whole process. And then the mood changes, and my delightful husband once said to me, you know, women have good times and bad times of the month, and if you blink, you miss the good time. So you can start to see women moving from a phase of sort of getting a bit premenstrual and grumpy to that becoming a more consistent phenomenon where you realise that you're surrounded by idiots. There is the anxiety, which can be a huge thing in a woman's life, often turning up quite early in menopause and often quite debilitating, even in women who've never had any mood or mental health issue in the past. Now, the other symptoms that we see that women very commonly talk about are the weight and body shape changes, and I think this is the symptom that drives most of my patients the most nuts. Because we see a whole heap of changes metabolically at menopause. So we see big drops in the amount of energy that the body needs to fuel itself. So if you keep doing the normal healthy diet and exercise that has kept your weight really stable for all of your life, at menopause, because you need less energy, you will start to gain weight, and the weight tends to shift around the tummy and it can stick like glue. So that, I think, can drive people potty. But it is a time that if you do start to put in some changes with diet and exercise, you certainly can see some rewards from that. We do see quite a lot of changes in short-term memory. Women start to lose words and forget names. Some of that's related to sleep. There is some very nice research that shows that this part of a woman's brain actually functions at a very, very high level prior to menopause, and all that happens to us at menopause is we drop to the same level that our male partners have been. So we notice it, but it's not all bad. And it is something that does go. It's never very clear whether this is something we just get used to it and adapt, or whether it does actually get better with time. And then most of us are aware that we start to get a bit wrinkly and the skin gets a bit thin and a bit dry. We'll start spending a lot of money on anti-wrinkle creams. So those are the symptoms we experience. But I think one of the important things that we deal with is not just thinking about menopause as that kind of acute time where these things are happening, but also look into the future, because menopause, with the hormones disappearing, is also a time we start to see other medical problems emerging progressively. So things like osteoporosis and fractures, and obviously increased risk of heart disease. So women go from very low rates of heart disease, and we rise steeply in terms of that risk after menopause and actually cross the male line within about 10 years. So we lose that protection from our hormones. So what do we do about it? Well, I think it's a very personal choice. We do have a wide range of options, and I think often women are very good at just trucking along and keeping on, and not sort of stopping and thinking, well, maybe there's something I could do about this, because if it is having a significant impact on your quality of life, your relationship, your ability to work, then get some help. Because over the last 20 years, I think in particular, with all the controversy there has been, mainly in the minds of the media about the safety of various treatment options, women have often felt that there's nothing that can be done and they just have to, grin and bear it. But that is not the case. We've got some very safe and effective therapies. Now, if we start initially and just run through some of the information we have about hormone therapy, because this is really where the controversy is, at least I think in the minds of most of the public, and also amongst our medical colleagues. So as Richard has said, we give our hormone therapy in two ways. You can either give estrogen alone if someone's had a hysterectomy, or we combine it with some form of progesterone if a woman still has her uterus, and the progesterone's just there to control the bleeding. Now, if you want to reduce the last 60 years of research into a couple of lines, then the next little categories up there tell you what the benefits and what the risks of hormone therapy have been shown to be. So we know that it obviously makes people feel better. The symptoms, if you get the dose right, will go away. We know that it significantly reduces the risk of colon cancer, fractures, halves the risk of heart disease. It reduces the risk of death from cancers, from stroke, from dementia. And the studies have now shown when you're using estrogen alone, it also significantly decreases the risk of breast cancer. So the problems with hormone therapy really fall into two categories. So there are the age-related risks. So if, as some of the research studies have done, you start it much, much later in life in women who are well into their 60s or beyond, way past their period stopping, then that group of women, if you give them tablet estrogen, not patches, but tablet estrogen, have a slightly higher risk of clotting. So we're talking about an increase of a couple of extra women per 10,000. And then the breast cancer risk, and there's still considerable debate about when that might change, but we only ever see it potentially increasing when the two hormones, estrogen and progesterone, are used together. And that risk seems to be directly related to the choice that the doctor makes in terms of what progesterone they use. So if they prescribe a natural body identical form of progesterone in capsule form, that appears to have a far lower risk than the old-fashioned synthetic ones. And we are extremely hopeful that Pharmac are about to fund the more natural forms of progesterone so that everyone, regardless of income, can afford to be on what is a much safer regime. So I think that the risks and benefits are a little bit different to what's been out in the public arena, where the media have very much promoted the very negative side of things. But there are women who don't want to take hormone therapy, can't take it, and so we do go through the whole range of options that we've got, whether that be talking to women about diet and exercise, helping them lose weight so that the flushes get better from the weight loss. There are a range of herbal and alternative therapies. If you go into a health food shop, the shelves are stacked with products, and it's very hard as a layperson to try and work out what works and what doesn't. Most of them have been tested. Most of them don't work, but some do. So St John's Wort and Maca, we do advise women to trial if they want a low-key option for mood management. Hypnosis, weird though it may seem, is good for flushes and sleep and mood. Remifemin is a German product. It's been around for about 60 years. That helps with flush control, with sleep and with mood. And then cognitive behavioural therapy and mindfulness. There are other techniques that you can learn that do help with symptom management as well. And then the rest of the gobbledygook on that slide are all the other medical things that we can prescribe that are not hormones. So these are basically drugs that have been designed for other purposes in medicine, whether it's using a specific family of antidepressants, some of the drugs like gabapentin, which we use for back pain, oxybutynin, which is a bladder drug. All of these help with menopausal symptom control. So even in the women who've had breast cancer, where we're not going to be jumping onto the HRT in a hurry, there are plenty of other safe and effective options that you can access. And then just to sort of reiterate the wide range of options that we've got for the genital and the sex-related issues. And even in the chemist shop, you can access the vaginal moisturisers. So things like Silk and Replens. These are physiological things that you can apply to the vagina. They stay there for a couple of days at a time, so you don't have to necessarily reach for the lubricant every time you want to hang from the chandeliers. You can have something ready for action. If it's a little bit worse than that, obviously the estrogen creams and pessaries are available. And these are very safe. You get very little absorption beyond the pelvis. So it's very safe to use even in women who've had breast cancer or ovarian cancer. What we often do is say to women to throw away the applicator, which you're supposed to keep using, and wash between uses, which is kind of a bit icky. But use your finger. The finger is a far better way to apply the cream both to the outside around the vulval area and then inside into the vagina. And that's what the Mona Lisa looks like. So that's the laser that Richard talked about. So this is the same kind of laser that we've used to get rid of wrinkles as we get older from our face, and it puts the wrinkles back into the vagina. So it kind of transplants. So the analogy is what it does to that peach. So you go from sort of slightly off and a bit old to juicy and plump and peachy. So that is a technique that's available, and it does seem to have quite astounding effects in some women. So if the simple things, haven't been that helpful, this is another option that we've got. But just to really finish and coming back to that bridge analogy, I read this in a new book that's just about, well, it's actually just hit the shelves this week. It's called the Menopause Manifesto. It's one of Jen Gunter's books. So she's a OBGYN in the US, and she's written books on the vagina. So the Vagina Bible is a stunning book of hers, and she's just written this menopause one, and she talks about menopause being this bridge. And I think it's a far more positive way to think of the whole experience rather than focusing on all the negative stuff that we sometimes dwell on in these talks. And certainly for the women that Richard and his colleagues often see who've had terrible reproductive years with awful pain, heavy periods, then getting out the other end of menopause is like a dream come true. So not all doom and gloom. I will finish there. Thank you.
As you can imagine, Anna is in great demand. And so I have to advise you at this point that Anna can only take GP referrals to her practice with us, and her clinics are very full. However, there's a however, we are absolutely delighted that tonight we can introduce you to a new member of the Oxford Women's Health team, and that's Dr. Catherine Smart. Catherine is a GP. Actually, Catherine, I'll ask you to stand up. I'm going to embarrass her greatly. So Catherine is a GP with a special interest in women's health, and particularly menopause, and she'll be working alongside Anna in our menopause centre. So thank you, Catherine. So our third speaker this evening has dedicated more than 12 years to developing her physiotherapy practice at Oxford Women's Health, and she's a very much valued member of our multidisciplinary team. So please welcome Julie Dennis.
It's nice to be here this evening. I was thinking about how to present physiotherapy in amongst the sort of medical side of things, and what I realised is that, and what I get often asked is, what the heck does physiotherapy have to do with menopause? So my sort of focus with this chat tonight is around why physiotherapy. What can I do at this particular point in a woman's life to help out? So what I say to that is, if you've got a bladder, if you've got muscles, if you've got bones, and if you've got joints, then there's a solid chance that I might be able to help you out, and also give you some ideas about how to manage some of the physical changes that might be happening through this midlife or menopause. And what I often find too is that some of the changes that happen can happen quite quickly, and that might happen because Rich has done some surgery, or as he's also talked about, there's potential for treatment for things like cancer. Chemotherapy, radiation may actually accelerate that change, and that can bring about some abrupt changes. So, first of all, we'll go to the bladder. So I see some of you getting up and having to use the toilet, because it's reached that time. So when menopause is occurring, obviously with estrogen being reduced, there's a general wasting away of muscles, and that can affect the vagina as well as the urinary tract. So the lack of estrogen may weaken the bladder, so it's obviously trying to hold the urine, and the urethra, which is the tube that carries the urine out of the body, they can actually be compromised in their ability to do those things. So that's when control can become some of the issue. So some of the things that you might encounter are suddenly that you need to go to the toilet more often. You absolutely find that number of times you're visiting the toilet during the day is increasing. And then there's also the inconvenience potentially of having to get up at night, and especially in winter, no one wants to really have to do that, but that is another thing. And once again, we talked about the quality of sleep, and made a reference to that. And of course, having to get up to use the bathroom can be very much an interruption. You may also experience an irritable bladder. You might find yourself needing to go to the toilet in a hurry. And obviously, there can be times that when I hear people talk about not actually making it in time, so clearly that can be something that can be incredibly inconvenient. So again, menopausal urinary symptoms can also be caused by pelvic organ prolapse. This is not something that people want to generally face up to, but gravity is cruel, and sometimes the organs of the pelvic area will drop into the vaginal space, and that can be also, if we look back historically, it can be because of the vaginal birth, and any trauma that happened there may have put extra stress on those pelvic floor muscles, and that can actually then cause some of the urinary issues. So non-hormonal treatments for bladder are generally trying to avoid the stress on that pelvic area. So one of the things I often chat about to people is just simply knowing how to breathe well and not holding your breath when you're under stress or strain. And in winter, I hear a few coughs and things going on. A persistent cough is one of the most triggering issues, and I do see a lot of people in winter who have had a bit of a bug and can't throw off the cold and the cough, and managing that well is really an important part as well. So we talk about pelvic floor strength as a really important part, so that's something that I'll be doing, assessing how well you can connect to your pelvic floor. We also might discuss bladder training techniques, and that's increasing the bladder's capacity to hold urine, and also controlling the phasing of time that you actually have between urination. I'm always about the drinking of water. That's an important thing. If you don't drink water, then the urine becomes very concentrated in the bladder, and that itself can be a trigger. And obviously all of these things are affected by the weight, and maintaining a healthy weight is really important. Again, breathing always contributes to changes in pressure within the abdominal area, so that's something I also focus on. So, joint pain and stiffness. I read something in the course of sort of preparing for this talk, and they say that up to about 50% of menopausal women experience some sort of joint discomfort, stiffness, or it could even be swelling. And I think, very much in the small joints, but also in the neck and shoulders, in my experience. And often at that time of life, if you go to the GP, potentially saying, look, I've got these things going on, it can possibly be put aside and going, well, it's just osteoarthritis, that's what getting old, that's what happens. But I agree, sometimes a little bit of hormonal support can make a jolly big difference to the joints. And unfortunately, if someone has joint pain, there tends to be a bit of a downward spiral of less exercise because of that joint issue, potentially then gaining a bit of weight, and that of course adds to the joint pain, so it's a bit of a vicious cycle. Also, as the hormone levels begin to fluctuate, one of the things I often see is tendons being inflamed. And again, as Anna mentioned, the classic area for that is around the hip, and the big tendons there under quite a lot of load. The bursa, which are little sacs of fluid that help to cushion between the bones and the tendons, can get inflamed, and that's when I hear people say, well, I just can't sleep on my side anymore, it just is too painful. So just remember that could be inflammatory, and not that you suddenly need a hip joint replacement. So, moving on, one of the long-term effects of reduced estrogen is the effect on the skeleton and the bones. And remembering that we need estrogen to actually help lay down bone. So with age and reduced estrogen levels, there's an increased risk of progressive loss of bone strength, and that can lead to the bone thinning and osteoporosis. So the bone loss itself doesn't always cause symptoms, but it's not until a fracture occurs, and it can be a result of a simple fall, especially in the older years, and obviously a fall on the hip is quite a significant issue. It's estimated in some reading that I did that by the age of 70, 1 in 2 women will have had a fracture that relates to osteoporosis. So that's pretty scary stats. So weight bearing and strength training exercises are really vital for building up the bone and muscle resilience. And I think the point I would make is that maintaining joint health by remaining fit and active, maintaining flexibility is essential. And exercises like Tai Chi, yoga, Pilates, swimming are often a lot more suitable because they're not so high impact. And as Anna also said, yeah, this is a big thing that counts into all of these things is the body shape changes. And it sticks. It is a challenge to make those changes. So this is where we talk about physical activity. So I've deliberately not called it exercise. I think sometimes we get a little bit sort of prescriptive and think everything should be about exercise. But physical activity, we say movement is medicine, I think is the message I want to get across here, that any movement is good movement and some is better than none. So don't always perhaps get it in your head that it has to be that you're training for a half marathon. Even just walking around the block and doing that consistently is better than sitting on the sofa. I would also say that dance is a wonderful way of moving, and it brings joy, which is a great thing if we're thinking about mood. And also gardening. It's a remarkable number of people that come to me and their main activity is actually in the garden, and what a great thing to do. I mean, I think that's the sort of thing I want to hear, is that people are moving and doing good things like that. And I guess, do what boosts your mood and makes you feel good. That's ultimately, you've got to find the thing that does that for you. So, if we go to here, what is aerobic exercise? What could be walking, swimming, cycling, aqua aerobics? I would say brisk walking, not just wandering. Jogging even, sometimes that's a nice easy thing to get out and do. And the recommendation, this is something that is fairly standardised now, that if you can do moderate intensity exercise for 2.5 hours, then that's what is the recommended physical activity. There's also a suggestion that if you do vigorous aerobic activity for at least 75 minutes a week, you've got the choice of either of those. But I would say I would generally recommend the 150 minutes or 2.5 hours myself. And again, if you're beginning with exercise, you don't need to think suddenly you're going to hop off and do that amount of exercise. It might start with just 10 minutes of light activity and you gradually increase that as it becomes a little bit easier. From a resistance or strength training option, again, we want at least 2 to 3 sessions per week, 20 to 30 minutes in duration, okay? The main factor there is to know what that is, and I think perhaps getting some guidance is a good idea if you've never lifted weights or perhaps used any sort of resistant band or anything. And essentially when you start, you want to use a weight or resistance level that allows you to do 12 repetitions of whatever movement it is, and then at that point you should feel like your muscles fatigued. If you're thinking, well, I've got those jolly 3 kg weights in the wardrobe, I might crack them open, well, that might be just something to get you going. I also think stability and balance is really important. So again, this comes back to pelvic floor. It's all very well just to talk specifically about pelvic floor, but it doesn't work by itself. It's got all those other muscles that it's working with, and making sure that you're able to integrate pelvic floor into everything you do during the day. So you might think, oh, well, how am I going to do that? But it could be as simple as standing and brushing your teeth and standing on one foot for that duration. So keep it simple, make it real and realistic, I would say to that. And also stretching was important to improve and maintain flexibility, mobility, and I guess setting aside time to stretch, especially if you've done a workout and you use it as a cool down, and that's when your body's really receptive to stretching, and of course yoga is a really good option for that. I also wrote something down. If you're experiencing hot flushes, it's recommended you exercise in the morning rather than the hottest part of the day. So I thought that was actually worth telling you and reminding you of. Other thing is, how do you get started? How do you stay motivated? Well, I think teaming up with someone is the key to success. Partner, friend, neighbour, like-minded person, whoever that might be, and that can make an absolute difference to keeping on track with your goals. So, my top tips, and I think these might be included in the little flyer that you have there. Definitely move it as medicine. I did use the exercise word in the sense of exercising regularly. And it's the things it do. It's quite simple. It circulates the synovial fluid, which is the fluid within the joints, increases blood flow, takes the oxygen nutrients to the joints and soft tissue. So all of that is good stuff. And again, it's helping you to maintain a healthy weight and improve your quality of life, and I think we should all try and build it into our daily routine. Drink water. Being hydrated just simply helps, with your bladder, with joints, with menopausal symptoms. I think hard to deny that, a simple thing to do. Breathing well, again, if you breathe correctly, you have the best option to calm your nervous system and maintain a good connection, maybe improve the connection to your pelvic floor. And there was going to be a fourth one, but I'm leaving that now to Sarah to talk about, which is to eat well, because that obviously is going to help the muscles and the body in general to have fuel to do all those wonderful things that I've suggested. Thank you.
Our gem of a dietitian, Sarah Widdowson. Sarah's very quickly gained a reputation for her refreshing approach to eating and the results she achieves with her patients. She makes it very real and achievable. So welcome, Sarah.
Last day. So I just wanted to direct your attention actually to start with the word there, second spring. And when I was doing reading tonight, not tonight, I didn't do this last minute, when I was doing reading for the presentation tonight, I was reading about how in Chinese culture they talk about menopause as being the second spring. And in that culture it's looked at, much like Anna's bridge analogy, a new phase of life, and women are respected and admired for, I guess, their status of wisdom in that culture, and I thought that was really beautiful. So tonight I'm going to talk to you about the dreaded weight gain in menopause, and it's a conversation that I have every single week with my clients. And I feel, I guess, privileged in a way that a lot of the time when women come to see me about the weight gain that they're experiencing, that's often the first time that they've come to talk to somebody about menopause in the second spring. So I'm going to talk about a concept called insulin resistance, which you might have heard of before. I'm going to talk about cholesterol, and talk about bones, and some supplement ideas as well. So I don't want to go into the hormone thing again, because I know that my wonderful colleagues have already done that, and I realise that I'm lucky last and we're a little bit short on time. But what I just wanted to bring your attention to is the great progesterone drop. And a lot of the time with menopause we're talking about estrogen, but the hormone progesterone is really important for our mood and emotional well-being, and research pretty clearly shows that it's the drop in progesterone during menopause that's linked to a higher perceived stress among women, lower mood, more anxiety and depression. And Catherine and I, just the other day, were having a conversation about how I think women going through menopause in this lifetime have a bigger job than women before us, because we're juggling so many different things. The women that I work with have responsibility, they're mums, they go to work, they have careers and navigating all the symptoms that you experience with this hormone profile going on is a lot different to women who had to run households. So I just wanted to acknowledge that. Right, I'll be a dietitian now, I can do that. So, on average, over menopause, women gain around 8 kilos, and the frustrating thing about that weight gain is it's often the movement of weight. So a lot of women will come to me and say that their body shape has changed over menopause, and they find it really, really frustrating. It's not uncommon for me to meet women who are going to work and have these amazing careers, and they're nourishing themselves on less calories that I would give a toddler every single day. And when we look at why does that weight change happen over menopause, it's due to the relationship between estrogen and the hormone insulin. And I just wondered, I can do the insulin talk. Has anybody heard of insulin? Yeah, people have heard of insulin. Normally people hear about insulin in the context of diabetes, but all of us make insulin. So basically, what we know is that with the decline in estrogen over menopausal years, women become more insulin resistant. And what insulin does as a hormone is when you have an increase in glucose, which is just a fancy word for sugar, when you have an increase in sugar after the ingestion of carbohydrate-containing foods, basically insulin's job, I call it the Uber driver to my clients. So insulin's job is to come into the bloodstream to pick up that glucose and transport it into your cells so you can actually convert it into energy. And it uses estrogen to do that. So we might call estrogen the Uber driver maybe, and insulin the Uber itself. So when we have less estrogen as we get older as females, we become more insulin resistant because our cells aren't listening to the presence of insulin anymore. So I hope that makes sense to you. What that means is you have higher circulating levels of insulin, and insulin is an anabolic hormone, meaning storage of fuel, and it's why a lot of women experience weight gain over menopause. The other thing that we know is that human beings can use 2 different fuel sources. So we have the ability to switch between fuel sources. We can use ketones or we can use glucose. And the brain, much like other parts of your body, needs a fuel source to function. And if you think about the fact that you're not so great at accessing that glucose anymore because you don't have the insulin being utilised, it makes a lot of sense why some of those mental clarity changes for women happen as well. We feel tired as well because we're not accessing that glucose the same, and I find with my clients when they have those high carbohydrate meals, they actually feel really buggered afterwards. I don't know if you've had the experience of, I always notice at conferences actually, they feed us lots of carbs and we're like trying to stay awake in the afternoon sessions, but when people have really high carb lunches or evening meals, the energy is really, really low, and that makes it really hard to do the wonderful things like Julie was talking about, like being active. So I just wanted to show you, and I have no idea if you can see this very well. Do I have a fancy pointer thing? Maybe. I don't know how to work this. I'll just point with my fingers. So this is, on the left is a standard diet, and I didn't make this up to look a certain way for the presentation. This is seriously stuff that I talk about all day. I don't ask my clients to learn to count carbohydrates. My professional opinion is only dietitians should be cursed with looking at food and seeing numbers. But if I kind of take you through a typical diet and how you can make some changes. So this lovely lady, I don't know what we could call her, Karen maybe. Karen starts her day, that's terrible, isn't it? Karen starts her day with 2 pieces of toast. If she's running short on time, she has a pretty standard Kiwi topping, like margarine and Marmite. I'm really sorry if there's Karens here. Another example is a cup of oats with a banana and maybe some honey if she likes it sweet. So that would be a carbohydrate count of about 30 to 60 grams, depending on if she chose the toast or she chose the oats. Then mid-morning, Karen's feeling pretty snacky, so she reaches for a muesli bar, which she's really proud of herself for bringing something to work, and I definitely would commend her on that. Now, muesli bars can be really dense in carbohydrates, so that might be up to 35 grams. Lunchtime is a pretty cheap and cheerful sandwich with standard fillings. And I just wanted to spend a little moment talking about the afternoon because this is the pattern that I see with most clients, and I don't know if you guys can recognise this pattern at all. I find that clients undereat during the day. We try and be these petite little sparrows in the middle of the day, or maybe we don't protect that lunchtime meal, and it means when we get home we're grumpy and we're hungry, and when we've got access to food we tend to eat a lot more. So Karen might have like several biscuits, she might have an apple and be snacking away on crackers while she's preparing dinner for her family. And that could be a 60-gram portion of carbohydrate, which if you think about the sandwich, that's the equivalent of having 2 sandwiches in terms of carbs. Then dinner, again, pretty standard. Her husband only likes meat-free veg, so they might have steak and vegetables and potato, or maybe they're adventurous and they have a stir-fry. So that would be a total intake of about 220. And I just wanted to show you, when I talk about reducing carbohydrates to reduce that insulin and help with weight loss in menopause, it's often actually not about eating less. What we don't want to happen is to basically trick your brain into thinking that you're going through a famine, so it becomes very careful with everything you give it. I want my clients to feel full and satisfied and to have energy, and food should make you feel good. It should help you have energy. So if you have a look at the second slide, or the second column rather, that breakfast is a really high protein breakfast, and what we know is that human beings are more insulin resistant in the morning. So we cope with carbohydrates less proficiently in the morning versus other times of the day. So if you can make your breakfast a really high protein hit, I think what you would find is your energy levels would be higher in the morning, and you probably actually wouldn't need morning tea. If you were hungry, absolutely eat, but you actually might find that you're not hungry at all. I would load her omelette with things like vegetables because they don't create a glucose rise and they're really high in fibre, which helps to keep carrying full. And things like a chia porridge would be a really good choice because, again, really low in carbohydrate but really high in fibre. So 1 tablespoon of chia seeds has 6 grams of fibre, and women need about 30 grams a day. So if she was making chia porridge with a couple of tablespoons, it would be, half of her fibre hit before 9 a.m. She might want morning tea, and I might recommend something like a milky flat white if she's a coffee drinker, just to get a calcium hit in, and if she's really hungry, a handful of nuts. Lunchtime, really focusing on colourful vegetables and lots of protein. And a little trick I give my clients is to try and aim for 2 hands side by side in terms of colourful vegetables, and either between a palm and a whole handful of protein, so really upping her nutrition there. Often I'll find that if I give lunch the love that it deserves, clients aren't hungry in the afternoon, but if they are, I again would recommend a protein hit. And then at dinner time, again, it's about pulling back on carbohydrate, upping the colourful vegetables. And that, depending on which choices we'd make across that column, that's between 40 and 75 grams of carbs, so significantly lower. The other advice I give to my clients to help with the weight gain and menopause and insulin resistance is to reduce their eating window, and that's kind of a nice way of saying fasting. I don't love that word. I think it's a nice word for starving. But reducing our eating window can certainly help. So your eating window is basically if you start eating at 7 o'clock in the morning because that's when you have breakfast, and you finish snacking at about 9 o'clock at night, that would be your eating window. So research has shown that reducing your eating window not only helps with your energy levels, it helps with weight loss, and it reduces levels of circulating insulin. So I would ask my clients, if they're not particularly interested in breakfast, they just eat because it's habit, then maybe they don't need it, and they could have the first meal of the day when they're at work, for example, or at morning tea time. And really paying attention to why we're eating in the evening. A lot of the time eating after dinner isn't because people are hungry, it's because they're stressed or they're worried, or they might be lonely, they might be rewarding themselves for a really crappy day at work, whatever it might be. So often we end up having almost a relationship with food conversation there. We also know that the more muscle mass that we have, the more elevated our metabolism is, and you've already heard tonight about the other wonderful benefits of exercise as well. So the more lean muscle mass you have, the higher your metabolism will be. Okay, moving on to cholesterol. So what we know is that estrogen has a protective effect on our cholesterol levels as women as well. And Anna had already mentioned that over the time of menopause, our risk of heart disease increases significantly. So just a little trick if you've had your cholesterol results taken by your GP already. This is how I got through uni. It makes me sound really dumb, I promise I'm not. So I think about LDL cholesterol as lousy because it starts with L. So that's the cholesterol that's not so good for your heart. And our LDL cholesterol raises when we go through menopause. Ways that you guys can manage that and make changes to your diet is to be mindful about alcohol intake. And I know that makes me such a dietitian right now. Being mindful of saturated fat intake, so that's the type of fat that you get from animal products, so your high-fat dairy, meat, that kind of thing. With your HDL cholesterol, that's the good one, and I think about that as happy HDL cholesterol, so we want that level to be higher. That cholesterol you can increase by increasing your fibre intake is the most simple form, and you'll notice before I was talking about chia seeds and trying to increase your fibre. So if you think about fibre as plant-based foods, basically the more plant-based foods we can eat, the higher our fibre intake. And you can start with tiny little changes increasing your vegetable intake by 1 to 2 serves a day, a serve being a handful, thinking about having a couple of pieces of fruit a day, using more things like chia seeds. I use psyllium husk with my clients all the time because it's really cheap, $6 from the supermarket, and it's relatively easy to add to things like smoothies and porridge as well. When I talk about bones with my clients, I use the analogy of sand dunes. So our bones are constantly being eroded and then hopefully being rebuilt with the help of estrogen. And obviously over the time of menopause, we don't have our helping wee friend estrogen to help us out, so we have an increased risk of bone disease. And from memory, I think 10 to 30% of people going through menopause will experience a change in bone mineral density. But there's 3 key things that you guys can do to help your bones. Number 1 is calcium and vitamin D, which is probably the obvious choice of what I was going to say. So calcium is a mineral that's obviously stored in our bones, and we get calcium from our diet. We get it from dairy products, but also fortified alternate milks. I feel like every nut under the sun is being milked at the moment, but there's lots of different milks that you can purchase. Just make sure that it's fortified with calcium. Tofu is a wonderful source of calcium, so maybe thinking about some new recipes that you can include that food would be great. Tinned fish with bones in it is another wonderful source of calcium. If you can get over the little eyes and the sardines or the little vertebrae and the salmon, that's a really good choice. Has everybody heard of vitamin D? And I'm assuming you know where you get that one from? Yeah, we kind of lack it down here. So vitamin D we get predominantly from exposure to sunlight. And it's just thinking about our risk is higher in Canterbury. The further you move from the equator, the higher your risk of vitamin D deficiency. So you might want to talk to your GP about whether or not a vitamin D test and a supplement would be useful, but also making sure that you get out into the sunlight. And it's another perfect segue for talking about exercise on your lunch break, or even just taking a moment outside if you're feeling really fatigued at work can be useful as well. The other thing with your bones is exercise obviously is really important for building your bones, and the other thing I wanted to mention is the mineral magnesium. With 60% of it stored in our bones, it's really important we have enough magnesium. Magnesium we can supplement, or we get it from foods like dark chocolate, which is nice to hear, but also dark leafy greens and nuts and seeds as well. And I guess one of my final tips is magnesium supplementation, and this is something I'm learning more and more about, and I guess anecdotally found it really helpful with my clients. So in a small trial they looked at magnesium sufficiency in postmenopausal women, they found that almost 90% had low levels of blood level of magnesium. And from a variety of different trials, we know that magnesium supplementation has been particularly beneficial for sleep quality and duration. We've already talked about it being beneficial for bones and also our mood. It can be really beneficial as well. It's a pretty safe supplement to take, and this isn't a conversation sponsored by a magnesium company or anything like that. The only adverse effect to magnesium, which might actually be helpful if you're a bit constipated, it has what's called an osmotic effect on the gut, so it draws water into your large intestine. So just be careful you don't take too much of it, you know about it. So my last tips are on the dreaded caffeine and alcohol consumption, and I saved them till last, so you need to put up with me for the remainder of the talk. I think it's really interesting whenever I talk about caffeine and alcohol with my clients, their body language is fascinating. They cross their arms and kind of like up and down, or sometimes they'll physically like push the wheelie chair away from me, like I'm coming for their best friend. I think it's just about acknowledging, like a lot of the symptoms that Anna's spoken about tonight, and Richard and Julie, is about fatigue and mood. And we use stimuli all the time to manage our emotions. If we have a shitty night's sleep, it's pretty obvious why we would use caffeine to pick ourselves up all day, to try and get through, maybe to access those reserves if we're feeling a really foggy brain. And then we use alcohol at night to wind down, to try and fall asleep at night. Caffeine and alcohol are vasodilators. That's why we have that lovely thing called an alcohol blanket. So it brings blood to the surface, and that can increase your rate of a hot flush. But also we know that alcohol intake can affect your brain's ability to use serotonin, and obviously caffeine intake affects your ability to fall asleep at night. Does anybody know how long your half-life of caffeine is? How long that thing stays in your system for? It's about 8 hours. So any consumption after midday is likely to be in your system when you're trying to wind down at night. All I ask of my clients is do an experiment. Try 3 weeks with reducing caffeine and alcohol, and if you notice a difference, maybe that's enough to keep you motivated to keep up with change. And if you don't notice a difference, maybe there's something else you could change instead. Spicy foods can also contribute to hot flushes as well. And the last thing I just wanted to talk about, again, this is me not being a dietitian, and I said I really tend to do this, but think about rest and joy as just as beneficial for looking after yourself in that second spring, just as beneficial as anything I've told you tonight about food or supplements or exercise. It's really important that you take the time to look after you. And that was my spiel.
Thank you, Sarah. So in conclusion, thank you very much for coming along this evening. We hope you found it worthwhile and that you feel more informed about the options available to you. We encourage you to talk to your friends and family members, to your GP and other health professionals about any symptoms that cause you concern. We appreciate that it's a topic that women want information on. In fact, you may have seen we've actually scheduled another event because this one filled up so quickly. So that's on the 5th of July if you know of anyone who missed out on this evening. You'll see some references to websites with additional information on the back of the flyer that we've given you. That's for the Australasian and the International Menopause Societies. They've got a wealth of resources and information and videos and fact sheets, the whole bit, that's on there. And there's also a lot of those on our website as well, links to those. Please put any questions you may have onto that little slip of paper I mentioned earlier. There is a box on the way out to pop them in. A final thought as we leave. I'm the non-clinical one. And that is that menopause is a natural process. Many women sail through it without a second glance. However, for many of us, its effects can be quite debilitating and often almost insidious. It's a big word, that one, actually. You suddenly wake up one day and realise that you're not yourself. Perhaps someone close to you has commented. You feel like you're trying to cope and trying to keep on top, but it may not just be down to the fact that family or work or whatever are just a little demanding right now. There may be a reason why you're feeling so tired, as our experts have alluded to. Well, you're waking up several times a night, no wonder you're tired. You're feeling anxious when you never used to. And yes, I'm speaking from experience. I'm very happy to share my story because it's been a huge wake-up, and I work with these people. I can call Anna into my office and say, is this normal? And she goes, no, you need to up those patches. Great, changed my life. So, speaking from experience, those hormones have a lot to answer for. So be good to yourself and listen to your body and get some help if you think it might change where you're at. A huge thank you to our wonderful presenters, Richard Dover, Anna Fenton, Judy Binns and Sarah Widdowson. Thank you very much. A huge thank you to the staff of the piano for enabling us to hold this in this wonderful venue. Thank you, you've been just fantastic. And also thank you to the staff of Oxford Women's Health who have come along and given up their evenings to help us this evening. Thank you, team. Really appreciate it. And a final thought as you leave, and it's what Sarah actually alluded to, and it's something I've thought of a lot, and that is that our generation of women are demanding a lot more of ourselves during menopause as we cross over that bridge than our forebears. We're superwomen, and we expect to be. We're juggling often full-time jobs as well as our parents at different stages. We've got children, sometimes still at home, and we might have even grandchildren as well. And we're still wanting to have a life and all that goes with that. So is it any wonder when sometimes we may feel overwhelmed when the hormones tip? Please talk about how you're feeling with someone. It really can make the world of difference.